When do we start, Salim Bhai?
Just in a minute.
Okay, sure.
Good afternoon, everyone. Let us welcome you to the third session of the second SANEM Annual SANEM International Development Conference, SIDC 2021, COVID-19 Recovery Context and Priorities. Our this session will be chaired by Dr. Savina Faiz Rashid, Professor and Dean, BRAC James J. Grant School of Public Health, BRAC University, Bangladesh. We also have Dr. Rumana Haq, Professor, Department of Economics, University of Dhaka, as a discussant in the session. In the session, we have four papers. Perceptions and attitudes towards vaccination against COVID-19, evidence from Bangladesh. The paper will be presented by Dr. Shafin N. Shimul, Associate Professor, Institute of Health Economics, University of Dhaka. Then we have Evaluating South Asia's Pandemic Preparedness by Chatuni Pabashara, Senior Research Assistant, Lakshman Kadiram Institute, LKI, Sri Lanka. We have impact of alternative non-pharmaceutical intervention studies for controlling COVID-19 outbreak in Bangladesh, a modeling study by Dr. Mafakar Hassin, Adjunct Lecturer, Institute of Health Policy, Management and Evolution, University of Toronto, Canada. And our last paper is on COVID-19 and mental stress among the urban youth of Dhaka city by Sarah Farheen Khan, Program Assistant, International Center for Climate Change and Development, Bangladesh. There are only a few housekeeping rules. Apart from the chair and the chair discussion and the paper presenters, all of you are requested to keep your video off and microphone muted during the session. For the paper presenters, they will get 40 minutes for the paper presentation. On the 12th minute, there will be a notification from us saying 2 minutes left. And during the open discussion, all the participants can send their questions to the paper presenters. Kindly put your questions in the chat box and kindly mention to whom your questions are directed to. Without any further ado, I would like to hand over the mic to our session of the chair, our session chair, Dr. Savina Faiz Rashid.
Hi, good evening, everyone. I apologize. My video is not working, but that's okay. I don't know, there's been a glitch, but I'm not very good with technology. So welcome, and it's a pleasure to be here. And thank you, it's an honor to be invited and chair this session. I really wanted to say this is a very timely sort of session. As a medical anthropologist, contexts are so critical, particularly if we look at populations, communities, if we try and understand the heterogeneity, the diversity, but also the areas that are being covered from vaccines to vaccine hesitancy, raises all kinds of questions on not only access and political economic, but historically, the relationship citizens have with the state. And I find it very useful to, I took great pleasure reading through the PowerPoint presentations. I read some of the papers. The other one, we've got a bunch of sort of a group of really distinguished, really smart colleagues around the table. So I'm not going to go on too much, except to say that the areas that are being covered from vaccine hesitancy, which is a huge issue in the research we're also doing. And then if we look at, preparedness and health systems, this brings into all kinds of questions around gaps, existing systems, but also global and national accountability and citizens' rights. Mental health of young people, I think mental health is critical for everyone. And I think for young people, they're extremely vulnerable because they have less sort of resources or coping mechanisms, and they live a life in a particular way and they have certain aspirations. We as adults tend to be a lot more jaded and cynical over life, but young people, it's like they look forward to the future. And something like COVID has really taken them back in terms of what do they do with their lives. And the last one, is about, sort of non-pharmaceutical interventions. And I think it's very important because when we look at, effectiveness around school closures, hand washing and social distancing, we need to understand from an anthropological or psychological perspective, as we move forward, what are the reasons why people don't want to uptake certain kinds of behaviors? And it's extremely important in terms of how do we implement this well in order to proceed with, opening up schools. So I'm not going to go into too much of this, except to invite the next speaker, who I know very well. In fact, he worked with us closely. He was at the school. It takes me great pleasure to see Shaifun Shimul Bhai, I should say, who's going to be taking forward with a group of colleagues. I'm not going to mention all the names. I'm sure Dr. Shaifun will on his presentation on perceptions and attitudes towards vaccination against COVID evidence from Bangladesh. So thank you very much, Dr. Shaifun.
Okay, so let me share my slide. Can you see the slide?
Yes, we can.
Okay, great. So first of all, I would like to thank you, my teacher, direct teacher, and very famous economist, Salim Rehan sir, and also Sabina Appa. She was also my direct mentor when I was in Breck School of Public Health. So it's great to see so many respectable faces in the same platform, even though it's virtually. If you could meet physically, that would have been better, but still, it's better to see all of you. So this is joint work with our other colleagues. And at the beginning, I want to mention that basically we plan to have 3 phases of survey. So we conducted 2 phases, 2 waves, but we are also thinking to do the 3rd one very soon. So that's why the paper is not polished yet, I would say, very in very early stages. So here my all colleagues, it says some from IHE, Institute of Health Economics, and this is Shafiun Nain Shimul. I'm an associate professor at Institute of Health Economics, Dhaka University. And also I have few other colleagues, Mufakkar Hussain, who is also presenting on the paper, and Abu Jamil Faisal, I think is a famous person, and he's also a COVID advisor, one of the advisors from the government. And then 2 other our research associates. So we all put together our effort to come up with this paper. As I said, it's very early stage, but we'd love to have a feedback from you so that we can improve in our next version. So here is the outline. This is what I expected: introduction, objectives, methodology, findings, and recommendation. Since we don't get much time, I'm not going in details about literature because it is not just an academic importance, as Sabina Appa said. It is very important because all over the world we are grappled with this COVID-19, and it seems to be the only solution is the vaccine so far, because many countries have tried many other tools, other measures. It might have some impact in the short term, but in the long term, there is a real challenge whether that other measures can be useful or sustainable. So only sustainable solution, what we can see so far, is the vaccine. Now we know that only vaccine production is not enough. You have to make sure that all people get inoculated, and as well as and for this purpose, only supply side is not the issue. There's the biggest issue comes from the demand side. So we try to capture all those more of demand side issues in this study. So a lot of the supply side issues are not covered in this study. So this is what introduction I said, just that the only solution probably come up with this. At least we can vaccinate 60 to 70% people, then probably we'll be able to some sort of cope with this COVID situation. So we know that Bangladesh has started this vaccination program in February 7th, and which was very good in terms of many other countries was not able to start at that time. So we are very successful on that. And but before government has initiated this program, we did a survey. What people think, because if you remember that time in January or in December, there's so many rumor out there in terms of for its efficacy as well as and there's also geopolitical issues we already talked about, because the vaccine was being, it was manufactured in India, so that was a concern from some people that that because of the geopolitical issues, so many rumors are there. So that might have some impact on the vaccination adaptation or the hesitancy. So that is what we wanted to explore in, and then to kind of understand like pre and post launch of vaccine campaigns. So that's the objective. We try to see what was the people's perception or attitude before the program has been launched, and then afterwards. So the first wave was in January, when that vaccine program has not started that time, and then another one we did after the vaccination program has launched. And we'll be doing another one in coming weeks. Okay, so the significance, you already talked about it. Government is planning to vaccinate some number of people, and the recent budget statement, our finance minister said our government plan to vaccinate at 25 lakh people, that means 2.5 million people each month. That was the target. And even I mean, if you look at the last few weeks, or from in early February, there was a huge demand. We at least see that people were very encouraged to get the vaccination, but there was we say that we have seen that that encouragement was kind of bit slowed down at the end of March and April. So to make sure that we can vaccinate enough people, we are also we have to do our best to increase demand. So that's why this study would be incredibly useful for government policy adoption. So the methodology, I would say there is some. I mean, this is better to say it's kind of self-financed study. It's not financed for any organization. So. And then what we tried, because we tried to do the study very quick, and then we instead of going any cluster or kind of standard sampling procedure, we try to do sort of little bit convenience, you can say. Now we collected data from public locations, mostly bus stand, CNG stand, railway station, launch terminal, shopping mall, marketplace, which is kind of where you will see more people gathering together, religious places. So it was in January. And then if you remember, our COVID situation was not that bad during that time. And then in our second round, what we have done is because we have around 3,600 people's information, and we actually called 1,004 of them after selecting randomly from those, and then we kind of had a telephone call in the second round. So the first round was physical, face-to-face, and the second round was telephonic call. And one key things we want to mention that instead of just asking people whether you're willing to get vaccinated, we try to use health belief model. So the health belief model it's widely used, even though it started in 1950s. It's widely used study to understand people's behavior for this type of activities, including vaccination and other government health interventions. So we collected a very typical information with your socio-demographics and then information about COVID infection, and knowledge about their prevention, what kind of things they are doing, and knowledge about the benefit of vaccination, and then also facilitating factors, barriers, and then how much, whether they are willing to accept to get vaccinated, and how much they're willing to pay. These are the kind of information we have. So the results, I'll not go, but our results survey, I would say the sample is little bit not fully representative of the country, because we have more male. And to make sure that we have some, at least some female respondents, we actually went to household in many places, because if you remember, all the sites we selected, they are mostly the public places. So you may not find enough number of women there, especially in the rural areas. So according to our from this first round, what we found that majority people, 82% people want to get vaccinated. That is what they want. But whenever it comes to like, you know, whether they want to get it vaccinated immediately, then it becomes a different results. So in general, people are willing to get vaccinated. That was a good thing. But people want to see first and then decide. That was what we found. There's an interesting thing is about COVID. People, kind of 90% people believe that anyone can catch disease, but only 28% think that he or she can be infected. So I think that is also very interesting, because that is why probably you'll not see people don't, I mean, people don't wear mask because they think that I'm protected. I'll not get caught of this COVID, but someone else. So that is kind of interesting. And also only 51% were concerned about the efficacy, and 53% were complained about the safety of the vaccine. So there was a concern about the safety. That was the first wave. Okay, and then we said that willingness to get vaccinated ranges from 63% to 98%. And as I said, overall is 82 point something, which is around 83%. And then madrasa students has a lower acceptance of vaccine that time. And whenever it comes to how much people are willing to vaccinate immediately, I mean, they don't like to wait and see. Instead, they want to get the vaccine immediately. There's some variation across region. We see that in Sylhet region, there's lower, lower acceptance, whereas in the Rangpur it was high, and nationally it was 32%. So 32% people wanted to get vaccinated immediately. I mean, before it was launched, it was their perception. Okay, and then when it comes to willingness to pay, that time there was an kind of information out there is that the total cost was $4.5. So we just tried to kind of come up with that how many people are willing to pay that much, and only 46% people would not be willing to pay any amount for the vaccine, but about 20% would be willing to pay $4.5, and about 34% willing to pay a higher amount.
Dear presenter, you have 2 more minutes to end your presentation. Thank you.
Thank you. Yeah, thank you so much. So, I mean, it is kind of give an indication that what we know from the demand behavior, that if price goes up, you can think reverse way. If the price goes up, people want to get vaccinated low, so lower. And that is kind of interesting too, that I mean, if you charge for vaccination, that demand may be highly affected. So I'll skip this. In the second round, what we have found that the vaccine acceptance has declined from 83% to 57%. That was kind of really significant results. And also the reason people want to, I did not explain, but there is a 4 component of this health belief. One is the cues. I mean, whether his friends, his relatives are taking vaccine, that kind of thing. What they want to see first before they decide, and that thing has gone down. So that is also an interesting one. Since I have only 1 minute, I think I'll skip it. So what the recommendation we generated from this study is we have to remove all these rumors we have, and also make people have to be people should give the confidence that if there is something wrong happen, government will take care of that. And because also their counseling is important, because some side effects are very normal, but you have to make sure that people know it. And also there's a concern about the registration process, what we found in the second wave. So the registration should be simplified so that people can get easily registered and get vaccinated once we have that vaccination. And finally, we should have vaccine modeling to kind of how much vaccine we want to buy, and how can we storage, and how many people will get vaccinated. So you have complete plan from buying to execution, and the vaccine modeling can help in that case. So that's all from my side. Thank you very much.
Thank you very much, Dr. Shimul. It's good to see you, and I really enjoyed your presentation. I think we're going to move on to the next speaker, Evaluating South Asia's Pandemic Preparedness, Chatuni Pabasara, I hope I pronounced it properly, and her colleague. She's Senior Research Assistant, and she's from Sri Lanka. I'm going to leave it to her to introduce her colleagues and her study, and looking forward to hearing about this. Thank you. Do you have a presentation?
Yes, my colleague will be starting the presentation, so
Okay,
I'm going to
sure.
let her, to start.
Okay.
Yeah.
That's great. Would she like some support?
I think she can share now screen.
Okay. Thank you.
Thank you. I would like to start by thanking Sanem for giving us the opportunity to present our paper on evaluating South Asia's pandemic preparedness in their second International Development Conference. This paper was initiated by my colleague, Ms. Chatuni Pabasara, and myself after our increasing awareness of how COVID-19 has emphasized the need for pandemics to be recognized as serious and imminent threats to national and economic security. Hence, the need to explore how pandemic preparedness as a critical component of public health infrastructure, particularly in South Asia, can be evaluated. When we think about South Asia, a number of factors which make it a particularly vulnerable region to the outbreak of infectious diseases come to mind, with some being more obvious than others as presented here. However, the factor which struck us as the most compelling to initiate our research on, and which we would like to bring your attention to as well, is the growing threat of emerging zoonotic diseases to the region. According to the WHO, the Nipah virus is likely to cause the next public health emergency and is a growing concern to South Asia, given the number of cases that have already been detected in the region, particularly along the Bangladesh-India border known as the Nipah belt, and also due to its mortality rate ranging from 40% to 75%, which is significantly higher than that of COVID-19. Therefore, this notable factor, along with the other key factors included on this slide, guide the analysis of our paper in evaluating South Asia's pandemic preparedness. Participating here today, we are all aware of the immense number of lives the pandemic has negatively impacted and continues to do so. Therefore, considering the epidemiology of COVID-19 in South Asia, our research is motivated by how the lack of robust pandemic preparedness plans and poor resource allocation have exposed the fragility of public health systems across the region, pushing them to the brink of collapse in the most recent and deadliest wave of the pandemic. The recent rise in average daily cases and deaths, as presented in these overwhelming figures, show how the epicenter of COVID-19 has shifted to South Asia. Therefore, it is with these understandings that our secondary research was carried out. Our research evaluates the effectiveness of South Asia's existing pandemic preparedness level during COVID-19, while recognizing the more favorable tools and mechanisms used in Southeast Asia. Southeast Asia is of particular interest as a comparator region due to it also being a sub-region in Asia and having similar vulnerabilities to zoonotic diseases. Additionally, both sub-regions maintain regional organizations that promote intergovernmental cooperation in various areas, including public health security. Data on indicators influencing pandemic preparedness in these two regions were gathered from secondary data sources for a comparative analysis. Indicators include components of the Global Health Security Index, government healthcare expenditure into resource allocation metrics, and social healthcare expenditure metrics. Overall, our research draws on findings from the challenges posed by COVID-19 on public healthcare services, highlighting the need for sustainable investment into public health security and resource allocation. In evaluating South Asia's pandemic preparedness briefly, we find that the region is exposed to future pandemics and future waves of the current one, given its limited public health infrastructure, made worse by its socioeconomic vulnerabilities. In addition to limited financing for resource allocation, countries also lack a pragmatic approach to national plans, lacking guidelines and laws in place for the surveillance and control of zoonotic pathogens that are an increasing concern for public health in the region. Cooperation is also lacking through organizations such as SARC. Although there was an attempt for regional cooperation against the pandemic in March last year through the COVID-19 Emergency Fund, progress towards this and the development of a standard pandemic protocol has been limited, while in comparison, ASEAN has played a more active role in this regard. Going into more detail, looking at the Global Health Security Index, which evaluates the capacities and capabilities of countries to prevent, detect, and respond to public health emergencies, and essentially assess the robustness of healthcare systems on a national level, we see here that in 2019, South Asia scored poorly in this index with a score of just 36.6 out of 100. Its performance across all index categories was less than satisfactory, performing particularly poorly in terms of health systems, prevention, and rapid response. The health system category, which was the lowest category overall in this index, includes indicators that assess the capacities of national health systems to handle public health emergencies. Therefore, when we look at resource allocation in the region, South Asia's poor performance in this is evidenced by the limited number of hospital beds available per thousand population. This limitation was clearly evidenced during the COVID-19 pandemic when South Asia faced a widespread shortage of beds during the latest surge in cases, causing patients to be turned away at hospitals and forced to find treatment at home. Additionally, the region also faced shortages in the number of skilled healthcare personnel available to treat the growing number of patients. Adequately equipped and staffed laboratories is another crucial component of a public health system, allowing for the rapid identification of specimens. During COVID-19, given the size of South Asia's large population, the number of PCR tests remained insufficient. And as we know, low levels of testing leads to lower case numbers. This masks the actual number of cases present in the community and therefore undermines the ability of policymakers to make timely and effective decisions to curb the spread of the virus. As policymakers often hesitate to act on ambiguous warnings, the availability of this precise information allows them to take more specific action. Over to Ms. Pabsara, who will expand on our research findings in more detail. Thank you.
Hello?
Yes.
Okay, sorry. Yeah, thank you. So our research findings highlight that the region's overall resource allocation to the health sector remains poor. And we can see that in the health expenditure numbers in South Asia, which remains below potential, especially in the region's most populous countries, India, Pakistan, and Bangladesh, where average expenditure levels are well below those in Sub-Saharan Africa, low middle income and low and middle income. And government expenditure on health was highest in the Maldives, where expenditure accounted for 6.6% of GDP. And Maldives was also the only country in the region to spend over 3% of GDP as recommended by the WHO. And South Asian governments on average allocated around 6.9% on health as a share of general government expenditure. However, these expenditure shares varied across the region. And as you can see, Maldives is clearly an outlier in terms of health spending in the region compared to other countries. And Maldives' spending efforts are reflected in the country having achieved lower mortality rates, high life expectancy, and near universal immunization rates. And Next, looking at this, the insufficient allocation of resources to health services by national governments in South Asia has limited the equitable access to health services, increasing the burden of out-of-pocket expenditures by households. And the proportion of the population that spends more than 10% of household consumption on out-of-pocket health expenditures is significantly high among South Asian countries. And this level of out-of-pocket expenditure is considered to be catastrophic because it limits the consumption of other non-health goods and services. So these high levels of out-of-pocket spending are a reflection of the poor allocation of resources into healthcare by national governments, as countries that spend the least on health services accounted for high levels of out-of-pocket health expenditures. And also, lower income households in this region are more likely to suffer jobs and earnings losses during crises, as demonstrated during COVID-19, and they are left vulnerable to health shocks due to inadequate government provision of healthcare, as they are less able to afford emergency care through private providers compared to wealthier households. So next, looking at the capacity for resource allocation to health in South Asia, we can see that spending capacities are constrained due to tight fiscal positions. And this is often the case because of revenue generation through tax collection remains low, below potential in South Asia, mostly as a result of low levels of formal employment, tax exemption and evasion, and weak tax administration, which eventually increases fiscal deficits. So in addition, while some countries in the region do face elevated political and security threats, the human cost of the COVID-19 pandemic has shown us that a pandemic could kill as many people as a deadly war. Yet, countries in South Asia tend to allocate greater amounts of resources towards defense spending than on social sectors, in spite of the region's socioeconomic inequalities and the growing threat of zoonotic diseases. So, next, we look at our comparator region, Southeast Asia. So despite recent surges due to highly transmissible variants of COVID-19, Southeast Asia was in large part able to outperform the rest of the world in managing the pandemic in 2020, with countries like Singapore, Vietnam, and Malaysia being held as success stories. And Southeast Asia is a region that is identified as a hotspot for emerging zoonoses and infectious diseases. And due to past experiences with infectious disease outbreaks in the 2000s, the region was better equipped to detect, respond to new diseases. And on average, Southeast Asia as a region scored 50.6 on the Global Health Security Index in 2016. And this tells us that Southeast Asia has an elevated level of preparedness compared to South Asia. So while government health expenditure as a share of GDP in Southeast Asia was lower than that in South Asia, the general government health expenditure for Southeast Asia's most populous countries, Indonesia, the Philippines, and Vietnam, was 1.8%
you have 2 more
of
minutes to
GDP.
enter your presentation.
This was significantly higher than that of South Asia's most populous countries. So spending levels were also comparatively higher across Southeast Asia than in South Asia. And high levels of resource allocation into health meant that out-of-pocket expenditure levels in Southeast Asia on average were well below that of South Asia. And now we look at the recommendations made by the Commission on a Global Health Risk Framework for the Future. This commission was established following the Ebola virus epidemic, and this commission provided 3 broad recommendations in mitigating infectious disease crises. And the first is the strengthening of national public health capabilities and infrastructure, and the second being international leadership and coordination, and lastly, the enhancement of research and development efforts in the infectious diseases arena. So our aim was to kind of look at Southeast Asia along the lines of these recommendations, and we have been able to recognize that Southeast Asia has made significant investments towards improving its ability to counter infectious disease in terms of all 3 recommendations. And while gaps and challenges do certainly remain, they have mobilized significant resources towards the establishment of new institutional bodies to improve public health infrastructure, and also to enhance regional cooperation, and also to increase research and development capabilities in the infectious disease research arena. And finally, looking at recommendations on how South Asia can improve its preparedness, sustained funding is a necessity, but this might proved to be a bit difficult in terms of proved to be quite challenging for national governments in the region. So fiscal space can be expanded using these mechanisms that we've laid out on this slide. And however, in addition to these mechanisms, there has to be country level interventions to also address the socioeconomic vulnerabilities that cripple South Asia's ability to fight infectious disease outbreaks. So this includes poverty alleviation, improvements in living conditions in densely populated areas, universal health coverage, and access to affordable medicines. And in addition to the national preparedness strategy, South Asia as a region should also devise a regional preparedness strategy given the transboundary nature of disease outbreaks. And in conclusion, Southeast Asia's experience with SARS and H1N1 exposed the weaknesses of its health systems and instilled the need for the region to recognize the threat of infectious disease outbreaks and invest in the necessary infrastructure. However, South Asia, on the other hand, was largely spared from infectious disease outbreaks in the past, but COVID-19 has clearly exposed the deep-rooted vulnerabilities of the region's health systems, calling for urgent action. And finally, the growing threat of zoonotic diseases such as the Nipah virus calls for the need to prioritize pandemic preparedness as a matter of economic and national security to prevent an adversity similar or worse than COVID-19 from happening again. Thank you.
Thank you very much for a very interesting presentation from Chetni and Ravindri from the Lakshman Kadir Gamar Institute in Sri Lanka. Very interesting, looking at pandemic preparedness and what are the gaps and fault lines that exist. I'd like to invite next Dr. Mufakhar Hussain, who's at the University of Toronto, to speak. He has a group of colleagues. They work together looking at the impact of alternative non-pharmaceutical interventions, strategies for controlling COVID. I think it's very important to look beyond sort of the NPI and look at other ways of addressing this issue. So I invite Dr. Mufakhar Hussain to please present. Thank you.
Excuse me. Thank you. Can you see my screen?
It's yet to come. Yes, now it's fine.
Okay, am I in presentation mode? Okay. Thank you everyone for joining, and thank you to Sanem for inviting us. My name is Mufakhar Hussain, and I'm going to present the paper on behalf of my team. I want to thank everyone in our team, Shapil Shimul, and Dr. Hamid and Dr. Nasin Sultana from the Institute of Health, Dr. Abu Jawan Faisal, who's a public health advisor, who's been critical to this project, and Mr. Jabin, who's an Oxford graduate, as well as Abdul Quddus, who's from James Cook University. Basically, our paper or our work has been focusing on modeling or estimating the actual and the projected number of COVID-19 cases in Bangladesh, and we wanted to focus on Bangladesh. And we are trying to use that modeling approach to understand what would be the effect of school opening, and how can we, what are the consequences of school opening in the middle of a pandemic, or while we're still in a pandemic. So essentially, Dr. Shimul, Dr. Hamid, and I have been working on COVID-19 projection since the beginning of the pandemic back in April of last year, and we've tried to use different methods. One of the more common method is the SIR method. It is called the Susceptible Infectious Recovery method. The other one is a time series method, Gompertz, and then we've also tried quadratic method. There's also other methods that are being used, sort of machine learning methods, such as the ones used by Facebook. People use different data sources, publicly available data sources, and in recent times, and people are also using Google mobility data to sort of use that data to come up with improved methods of forecasting COVID-19 cases. there's a significant level of uncertainty. And there's also changes in the non-pharmaceutical interventions. So by that non-pharmaceutical interventions, we mean are things like mask wearing, hand washing, social distancing, self-isolations, and common interventions that we have become familiar with since the start of COVID-19. So I want to just briefly describe what simple SIR model is. So SIR model is more of a compartmentalized model. It has a set of three differential equations, and it just tries to follow people from being susceptible to being infected to being recovered. So everyone in the population is not susceptible. You'll have susceptible people, and some of the susceptible people will become infected, and some of those infected people will recover, others will die. We don't have the deaths yet, but essentially it follows patients through time according to different stages of their disease. And this is a very simple, simplest case of the model. The one that we are using is more of an advanced case, and I'll go over what we're using. So through this model, we can develop things such as the rate of reproduction number, or the R0, and that comes from knowing the level of infectivity of the disease and the spread of the disease, or the rate of recovery. And then using that R0, we can also figure out what one of the common is that what is the sort of the vaccination threshold, or the herd immunity that needs to be achieved through vaccination. So that's where these, we typically talk of 60-70% new people need to be vaccinated. So if we assume that R0 is 4, then we will need to have a vaccination coverage, or vaccinating 75% of the population. And so that is, again, that is pre-COVID-19 sort of estimation. COVID-19 is throwing us all kinds of uncertainties that we are not, we are still so very cautious. So this is something that we have to keep an eye on. So once we started our modeling process, we came to know someone at Oxford, and through that process, we got in touch with sort of the COVID-19 modeling consortium at Oxford, hosted by two very experienced modelers, Lisa White and Nathaniel Hawthorne and Hooper. Both of them have been in the infectious disease modeling for a while, and they brought people in together. They developed a model and then allowed others to use this model. And so far, about 45 countries are involved. We have weekly meetings and updates, and we've benefited greatly from joining that. So Bangladesh is in the second stage. We have developed the model and have been presenting even to DG Health Services the results of this model, so on several occasions. So what does the model, what are inputs to the model? So inputs includes of the cases and deaths, mortality, age. This is an age-specific model. So the model tracks or follows every cohort or every age category. They'll have 20 age categories. Another important input is contact rates, country-specific parameters such as household size, virus parameters, hospitalization parameters such as the number of beds in the country. And then the model also allows us to select different levels of non-pharmaceutical interventions such as hand washing, mask wearing, and social distancing. There are others as well, but those are the three that we focus on. So this is an example of a contact rate, sort of age-specific contact rate pattern. So basically, this is a mathematical approach that was developed by Professor Jit some time ago. So they look at places of contact and how each of the different age groups contact each other. So, you know, how many 20 in a school, how many 20-year-old contact another 20-year-old in a day. So we have that data for Bangladesh that was provided. So that's also included, because rate of infection or transmission of infection depends on the number of contacts and where you have those contacts, and by age category. So those are the information that is used in our model. So the modeling exercise involves two sort of steps. One is a baseline calibration step, where we apply what we know and try to get the model to predict close to what the actuals are. And then we once it is calibrated, we then simulate and say, okay, in the future, our current assumptions will change, and if the assumptions change, what will be the effect? So these are some of the basic. This is a very short list. There are quite a few parameters that are involved. But as an example, we assume that in Bangladesh, 32% of the population will have immunity. The attack rate of 4% is the sort of the infection rate. There are 112,000 hospital beds and 600 ICU beds. The scaling factor is 1.1, and you know, and then these are the sort of at the bottom in the vaccinations, and we assume that 4% of the vaccination population will be vaccinated by year end. So, so these are some of the assumptions we made in the model, and then we also made some assumptions about the infection, sort of the NPIs, and in the top chart you'll see that, you know, there were working at home assumptions that we made, because during the early part of the pandemic, there was a holiday. The social distancing is what we looked at Google Mobility and changed it accordingly.
The recording has stopped.
Mask wearing is also something that we changed. And then hand washing is also something that we changed. We changed all this to make sure that our green line, which is our projected line, aligns very closely with the red line, as you can see, which is the actuals. So it aligns.
This meeting is being recorded.
The red line, the green line aligns pretty closely with the red line in both in number of cases and number of deaths. Okay, and so based on this, the model predicts that under current circumstances, about 47% of the population will be infected by year end, and by year end there will be about 20,000 deaths. So that's our baseline sort of projection. And then we thought about, okay, what is it that we really want to focus on? And that's where we got into the discussion on school closure. Because schools have been closed in Bangladesh for more than 15, 16, 17 months. For a country full of with 40 million students, whose survival is fundamental. The population's education is fundamental to survival or progress of the country. And so we wanted to see what are the options of opening schools, okay? Because already there's significant evidence out there of the negative effects of.
End your presentation. Thank you.
The negative effects of school closure, okay, including not only learning gap but also child marriages. There are evidence of psychological effects. And World Bank has said that there will be economic effect because of the dropout rates among students. So there are evidence out there that says that it is a very urgent matter. Okay, And then the other thing that we need to focus on is also that COVID-19 is not going away. In other words, some studies say that COVID-19 could exist well beyond, up to 2022. And based on our expected vaccination, that is indeed going to be the case. So what are we going to do? We have to figure out how to open schools. And so we tried to do two hypothetical situations. One situation is keep school closed, but continue with current NPIs, or open schools and also enhance NPIs. Okay, so our essential result is that opening schools with enhanced NPIs is the same as current, so opening schools may be a preferred option, because we say that at the current situation we are going to we are expecting total 47%, but if we keep school closed for one additional month and same NPI, we get 38%, but if we open schools with enhanced NPI, we also get close to 38% prevalence, and the death rates are also similar. So recommendation is that through coordinated effort, and by that I mean coordination between the different ministries, different sectors of the economy, different sectors of the government, and consistent with the WHO, UNICEF, or UNESCO guidelines, should formulate opening schools. Teachers and students should be vaccinated. You can also open schools in sequence, different age groups opening in different times, or open schools in different areas. And parents and broader community should be engaged, and there should be plans to recover learning loss due to extended school closure. That is the end, and thank you for listening, and happy to address any questions or comments after. Thank you.
Sabina, you have to unmute.
Hi, sorry. I'm having internet problems, so I apologize. It's been a bit of a nightmare. But thank you so much, Dr. Mufakkar. It was very interesting how you talk about community engagement, how you talk about the different factors and issues, because at some point we've got learning loss of magnitude proportions, and that's going to have a huge impact on future generations. I think we have a final speaker, last but not least, looking at mental health and stress among urban youths of Dhaka city. I think mental health and emotional health is a very important topic, given it's globally neglected, and it's very neglected in Bangladesh. It's stigmatized. And I think all of these topics are really, really important. I would like to invite Sarah Farheen Khan from ICAD to please present. Thank you very much.
Thank you so much. So, Assalamualaikum and a very good afternoon, everyone. I am Sarah Farheen Khan, working at the International Center for Climate Change and Development. I also work with several youth organizations like YOUNGO, which is the Children and Youth Constituency of the United Nations Framework Convention on Climate Change. So as you can see on the screen, today I'll be presenting on one of my research works titled the COVID-19 and Mental Stress Among the Urban Youths of Dhaka City. So firstly, my heartiest thanks to the organizers and all the participants today for attending the event. And I believe you are going to connect with me and my findings from the study, as I will be sharing with you some interesting yet dreadful side of the lockdown the youths of Dhaka city and the youth surrounding us might be facing. So moving on, I'm going to take you all through an overview of how the research was planned and conducted, the aim or objective of the study, the research methodology, results, findings from data collected, future recommendations, and we'll end with a conclusion. The COVID-19 pandemic has imposed threats on not only our physical health, but also our mental health since its outbreak. Besides the pandemic, the lockdown is affecting all groups of people in the world, either physically or mentally. Many youngsters are currently suffering a wide range of mental health issues related to anxiety, fear, isolation, depression, feeling lonely, and emotional outbursts, insomnia, and other sleeping or eating habit disturbances during the COVID-19 pandemic, as they belong to the most vulnerable or emotional age group. The panic caused by the infection from physical proximity has reached such a level that everything now is shifted from physically going out to virtual conferences like the one we are having right now. It could have been a physical conference if we didn't have a pandemic, but because of the pandemic, it's now a virtual, and everything now has shifted virtual. So along with the panic caused by the infection from physical proximity, other mental health issues like people's behavior are also being affected. Mental stress and anxiety is seeding physical sickness like obesity, dementia, diabetes, etc. Now we know that human beings are the most important component of the environment, and youth being the most strong and efficient component of the human beings need to be safeguarded. The youths today hold the ability to change the future of the society with their well-being and positive decision-making. But echoing to Ms. Sabina, youth are the most vulnerable and in the situation of COVID-19 as they feel trapped, staying indoors. Online classes and meetings are more taxing than the physical ones. Very few of us can still maintain the difference between AM and PM. We work and study on off days as well. There's always a tension to check emails and always being available. And this action of ours is causing damage to our mental health. We will be knowing the causations of mental stress shortly. I'm sure we all know that mental health is important. It's also widely spoken about these days. And the stigma of mental illness is overcoming as people are speaking about it. But during the ongoing pandemic, why should we categorically focus on the mental health of youths? So youth constitute of 18% of the global population, and children and youth together account for nearly 40% of the world's population, which is a lot. And according to WHO, mental disorders are the single most common causes of disability in young people. And untreated or unresolved mental health issues at young age can result in enduring consequences. So it is very important to restore their mental health before it takes turn towards something irreversible. I'm sure we all know Greta Thunberg, or we have heard about Greta Thunberg. She started her climate activism at the age of 15. There are many more youths striving to achieve and be heard. But will it be possible if mental stress becomes a barrier during the pandemic?
Have you completed, Sarah? Hello?
I think she got stuck. Maybe
Have we lost Sarah? Dr. Salim Bhai, what do we do?
I think there is internet disruption from her side. Yeah.
So I'm going to keep to
wait a little bit
okay.
And see if she can be reconnected.
Sure.
Yes, I think she's reconnected. Sarah, we actually only...
I'm back. I'm so sorry.
Sarah, welcome back.
No worries.
Please
Welcome
continue.
I'm so sorry.
Please continue.
Is it Sherry?
Yes, fine. Go ahead, please.
Okay, so so coming up with relevant questions for the survey instrument was another step. which could help in understanding the mental health condition of the survey respondents. As you can see in the right corner of the screen, the survey conducted was from 15th of May to 15th of August 2020. The survey participation was voluntary and their consent was asked before taking part in the survey. 150 young adults residing in Dhaka city from the age range of 12 to 30 took part in the survey. Takers were not pressurized to take the survey by any means. They took the survey voluntarily and the responses were recorded automatically in the eCloud, keeping the respondents anonymous. Each respondent was briefed on how the questions were, and if they had any problem, I was there to help them out understand the question. Let them answer. They chose whatever they were experiencing. And finally, after the data collection, data analysis was done, and the findings were rise in stress and anxiety. The government of Bangladesh imposed a closure of all educational institutions, both public and private offices, and a nationwide lockdown from 26th of March 2020 in an effort to control the spread of the outbreak, which led everyone staying indoors for their own safety. In the bar chart, it can be seen that 82 out of 150 youngsters remain stressed and anxious few hours of the day, which is quite a big percentage. Now being cut off from the love, support, and close contact of family and friends, and staying alone or not in a desirable situation has left few of them feeling isolated and lonely, having to deal with their problems all alone. Similarly, experiencing major changes in life, such as death or sickness of a loved one, loss of a job, being COVID-19 positive, or dealing with relationship difficulties can also bring overwhelming levels of stress. And experiencing multiple stressors at once can make one more vulnerable to depression. Now, stress can unfavorably affect sleep quality and duration. While insufficient sleep can increase stress levels, both stress and anxiety, both stress and sleep deficiency can lead to long-lasting mental health problems. Similarly, survey respondents were more likely to experience uncertainty, fearfulness, and isolated during current times. It was also seen that they experienced disturbed sleep, a poor appetite, agitation, and sadness for not being able to socialize. And it is clearly seen that they're in their sleeping pattern. Now, not getting enough sleep can weaken our body's immune system and lead to both weight gain and weight loss, as well as increase certain health risks such as cancer, etc. Experts name this state coronasomnia, where getting a healthy sleep is difficult due to stress caused by COVID-19. Other than that, young and middle-aged people are spending more hours focusing on digital screen. Their eyes are going through an exhausting endurance workout. Eye strain from hours of screen time can result in eye irritation, fatigue, or blurred vision, back pain, and headache, according to the survey conducted. However, distance learning has led to more out-of-pocket spending by our nation's teachers and parents. Unfortunately, families without sufficient smart resources and access to reliable internet may have severe stress on how to continue virtual learning with a limited income. 44% survey takers mentioned facing difficulties as such, and majority spend more than 10 hours on electronic devices, straining their eyes for entertainment purpose. And some respondents spend more than 12 hours on screen to attend classes or meetings. And we have recently seen how the youths are blindly involved in apps like TikTok, Likey, Instagram, and have a sort of hunger for followers, which are leading them to certain crimes as well. And being trapped indoors, some are involved in these applications that they are making inappropriate or unacceptable contents. Just recently, I watched a video where a young boy, I believe he was 15 or 16, and from a small town somewhere in Bangladesh, he was showing off his iPhone 12, which his dad got him. So his friends were asking, how did he convince his dad to get him such an expensive phone, as they were not so well off and the phone was certainly out of their budget. So the boy answered, I stopped eating and also wanted to cut my wrist because I needed that phone badly to make TikToks. So the dad had to sell the only asset they had, the only bike they had, in order to meet his son's needs. So getting back to the topic, as youths are seen spending so much time in front of mobile phones or computer, we can say that youths of Dhaka city are pretty much in threat of depression and computer vision syndrome. And it's not only in Dhaka city, it has become a general scene now. Moving on. So from the picture in the left, you can see that there are respondents with OCD as well. OCD means obsessive compulsive disorder. So who wash their hands up to 30 times a day in fear of getting contaminated by the virus. From similar studies, it has been found that people with OCD often wash their hands repeatedly until they get chapped or sometimes even bleed, and also stress a lot if they fear their close ones might be at risk of anything. So it's very difficult for them to actually maintain a stable mental health. Similarly, another finding is rising unemployment. Though this survey was conducted on young adults belonging to middle-class families, mostly university students and young professionals, it is quite shocking that nearly 41% of them are now coping with financial crisis and facing mental health challenges. The inability of less or no income or not being able to leave home for work adds on increased risk of mental health issues. Similarly, economic insecurity might further lead the main earning source of the family to loss of self-esteem.
Dear presenter, you have 2 more minutes to end your presentation. Thank you.
Thank you. Economic insecurity can further lead the main earning source of the family to loss of self-esteem and depression for not being able to provide for the family. Now, speaking of domestic violence, violence against women and girls has always been a social, cultural, and economic problem in Bangladesh. And as we are seeing in the dailies and news, it is evident that domestic violence has come to a rise. Even 33 out of 150 survey takers are themselves facing or seeing someone face domestic violence in their own household. It is indeed a great factor to cause stress and anxiety. Rights activists say that the lockdown has made women and children more vulnerable to domestic violence and abuse, as many of them are confined to their homes with no outside support. And continuing their relationship, possessiveness, and domestic services. Thinking the partner is bound to do the domestic chores. Okay, so honestly speaking, I didn't have any question related to the substance abuse data instrument, but I had questions like feeling good or having a good day. Mention the reasons, and this is that
I think our connection is lost. Probably we understood her presentation.
We should wait minutes for her to rejoin.
Sarah, I think she has rejoined. I think probably she was concluding. So I think, oh, Sarah, you are back. So yes, you can make your concluding remarks, please.
Sarah, can you hear us?
I have to say is it may take weeks or months to accept the new normal and managing the impact requires self-dedication. Yeah, I do. Am I sharing?
Yes, you should be concluding your presentation by now, please.
So in spite of all the trauma and negative effects the pandemic has put us through, there's still some hope that mental health issues often neglected in our country can now get an increased availability of support services due to more ongoing research on this topic. So thank you for listening, and I'm leaving my contact details here. Please feel free to reach out if you have any questions or suggestions on today's presentation. I'll be more than happy to receive any feedback.
Thank you very much, Sarah. That was very, very interesting. Mental health, emotional health is part of everyone's sort of everyday life. I'd like to now invite our discussant, Dr. Romana Haq, who actually I know very well. She's contributed to teaching at the school. We work together in the Bangladesh Health Watch. Great pleasure to ask her, Professor of Department of Economics, University of Dhaka, to share some of her reflections on the presentations. Then we'll open it up for some question and answer, open discussions, and then we'll wrap up. I'll just wrap up. Thank you very much. And I want to thank Dr. Salim for assisting in this process. Thank you. Yeah.
Thank you. So first, I would like to thank Sanem and Dr. Salim Bhai for inviting me to this session. And thank you, Dr. Sabinappa, for your excellent sharing, and all the 4 presenters for excellent presentation. So very briefly, I will try to give some feedback on the presentations and just sum up the key findings or some similarities of across these presentations. I will go one by one very briefly. So first, again, thank you, Dr. Shafiun, for excellent presentation. And this presentation rightly showed that before the vaccination, how people willingness to vaccinate, and then after this during the second round of the survey, they saw that that willingness has gone down, and he nicely identified some of the reasons. So these are really interesting findings, and I think government should really take care of the findings in their policy making and when they do the vaccine diplomacy and also vaccine management as well. So some of the recommendations, I think these are really excellent recommendations from Dr. Shafiun. I would like to focus on the information sharing and the rumors, because the way the media and social media and other fronts, they communicate different information, and the intake of those information across different groups of the people, having less education to even the very educated people, having very less understanding of the clinical perspective of vaccination, the side effects, and other longer term impacts. So how we communicate this information is really important. So I think this is something government really needs to take care of and work closely with ministries and media, that how to communicate this information accurately so that people really understand the types of vaccines, their impact, side effects, the age group, which one is safe for whom and why and how, all these questions. And I am sure that in the next rounds, we'll get more information from these surveys that which vaccines, the people's perception about different types of vaccine, whether there is any preference for any country, and if so, why these are. So that might also give some perspective of the government, that what psychological issues, are there for people for having different preferences for different types of vaccination. So definitely, this is the demand side that the study is looking at. So government can then look into the supply side as well and try to match up and may take different decision. So I have one issue just to raise here, that in the sample, it was I think in the first round 24% of female and 76% of male. So just to see if that creates any type of bias in these, as this is male dominant. And I understand that as the samples were, the recruitment of survey participants were from the renowned, different public places. So during COVID situation, I'm sure that women did not, appear in those areas. So that might be one of the reasons, and authors can also clarify, of recruiting less women from this bus stand or other public places compared to male. So I can see that it is the same cohort they're doing the survey. So if there is any appetite or any plan for increasing the cohort number of participants in the cohort and making some sort of balance of male and female, but I don't think that will massively change the main recommendations. Just developing the trust of the population, building the communication channel properly. I think that remains the same, but some sort of willingness across different income group, male, female, different areas that might be more interesting, and government can target the behavioral change communication for those pockets where the willingness is low. And as I think mentioned in the presentation, that for other factors, for example, for the second round, why I think I saw in the comment box that whether the propaganda or some other information for the current vaccination and some relationship, vaccine diplomacy, has any impact of this willingness. Then I will go to the second presentation, that is by Paba Sara. Please pardon me if I misspelled that. So this is again the presentation talked about the overall resource allocation and other human resource issues across Southeast Asian countries, which is also very important and interesting. And I can see that the situation in all the Southeast Asian countries are more or less same. Despite COVID situation, the resource allocation for the health sector or vaccine management still remains quite low. And the percentage of national budget for health sector remains less than 1% of GDP in many of these countries, which is really disappointing. But of course, out of pocket expenditure, and for these COVID situation, the catastrophic health expenditure can go up if people have to pay out of pocket for these COVID management. So that really highlights the importance of government spending for health sector. And I think this is really important to emphasize on health system of human resource, the number of beds from the government sector, that and financing, all these issues. Just one thing to add, that I think in Southeast Asia, one of the common things is that the financial management and the rules of financial management and the responsiveness or resilience of the financial procedure. So even if government allocates funds, it's very difficult to spend the funding given the existing financial procedure in many of these countries, especially Bangladesh. So we have to have some skilled personnel who are able to prepare any COVID or this type of pandemic response budgeting, and then negotiate with Ministry of Finance, get the budgeting, and then spend the budget. So these, from preparing the budget to execution, we need more skilled personnel on financial management, and who can also create a balance between pandemic response expenditure, and also avoiding any corruption while bypassing any layer of fund management during this type of emergency. So that's something I think these countries need to work together. I'm sorry for this call. Just a moment, sorry for this. So I think that's something common learning across all the countries. And that also reminds us that as all these countries are sharing the borders, like Nepal, Bangladesh, India, so we need to be very careful in COVID management, and there are lots of lessons that we can learn from each other during such pandemic. Another issue I wanted to highlight is that I said the joint efforts of all these countries for COVID management. Very briefly, the third presenter, Dr. Mofakkar Hussain, again, excellent presentation. And he reminded us that while doing this type of sophisticated modeling, we really need some real-time data and quality data across different types of variables. Some are clinical, some needs sophisticated assumptions. So I think a country like Bangladesh, where we really lack quality data, especially real-time data, where we have to take data from like some base year and we have to make lots of assumptions and apportion these and that sometimes undermine the this type of modeling, and people just question. But we also have to realize that we need real-time data and quality data to do this type of sophisticated modeling. So, and these are so important for the policymakers, for policy making, and the important dimensions that you showed across different areas, these and that. So I think this is a very good message to the government, as you all worked very closely with the government for policy making and central level, the COVID response team. So I think I request the Dr. Mofakkar and the team that to also coordinate with central government within ministry and others to strengthen the database and make sure that these type of data are available to the researchers also, so that they can do this type of modeling using those real-time data. And as you mentioned, for the education sector, fully agree. I'm just cautious of the time. So education sector is one of the sectors that is lagging behind. All other sectors could come up, but this is the sector which really needs proper planning now, that how to revive these laws. And as you mentioned, that staff vaccination or opening the education institute in sequence. So I think all these are very pragmatic and timely recommendations. So requesting the team to also negotiate with Ministry of Education and just share these findings. Last but not least, the FARA, again, excellent presentation on mental health, a very important issue. Mental health always neglected. Even this year's budget, though it is mentioned that autism and neuro disorder will be get attention, but generally overall depression, anxiety, and mental health always remained less, always had been less prioritized. So it is chronic. So we really need to raise our voice to allocate budget or give more attention to the national mental health in the strategy implementation. So we have National Mental Health Act now. National Mental Health Strategic Plan is nearly there. It has been approved, but the cost reduction plan will be approved very soon. But still, there are lots of gaps. We don't have any suicidal act, and always like implementation is really weak. So I think, as the presenter rightly mentioned, some other triggers due to mental health. There is other problems like violence against women or other cross-cutting, other impact also. So multimorbidity is something that we really need to take care of. So for mental health, I want to highlight that, again, the media has a very important role during this type of pandemic, and government need a multi-sectoral approach to coordinate with different ministries, just to make sure that the entertainment and other issues, communication, all these are done very sophisticatedly, so that people's and their mental health issues are taken care of. And as I said, the plans need to include mental health. The mental health should be prioritized, and in the plan execution and also budgeting. So I thank all the presenters once again for excellent presentation, and it was a very good session, and I really enjoyed all the presentations, because these are very not theoretical, but all these presentations has practical practical recommendation for the governments. I hope that the presenters will take it forward to the policymakers, and the research will be translated into policy and practice. Thank you, everyone. Thanks.
Thank you very much, Professor Romana. That was very useful. Yes, I have to echo your views that this has been extremely useful, a lot of learning, and very diverse presentations that cover sort of different aspects of health as we understand it, from the individual to the health service component. I think I would seek Dr. Salim's guidance. Are we just opening it up for questions in the chat box, or
yes, actually, we can request some of the participants who actually post a question there. They can speak.
Okay. There's a couple of questions.
Yes. Dr. Abdullah Shibli, if you want to speak, please. It'd be great.
Can you hear me?
Yes, Shivli Bhai, we can hear you.
Again, an excellent session. Enjoyed all the papers, which was for me a challenge because I was outside and had to use my iPhone. But my questions, I have a couple of questions actually. One is for Sarah, who presented some very interesting findings on the mental health effects of the COVID restrictions. I live out, well, I might as well mention it. I live in Boston and have had access to several studies which show that domestic violence and other forms of COVID-related anxieties have skyrocketed. And the question I have is for Sarah, do you know if in Bangladesh we have protection mostly for women who might be asked to either leave the household or are deprived of any, I would say, expenses or other forms of support from the partner? Does that make sense to you, the question? Whether women in Bangladesh have any support or legal protection. Let's put it this way, legal protection. Let's say I'm a husband and I don't like my wife, or I'm very stressed out during the pandemic, and I tell her, hey, I can't support you, so leave. What is she able to do? What kind of protections are provided by either the legal framework or by some other, I would say, NGOs or some other civil society support?
Yeah, I believe there are no organizations as such, but there are definitely a lot of women helplines these days. And we have always heard about education being the backbone of our nation. So if a woman is educated, if she knows the difference between right and wrong, if she can support herself, if she has a child, if she can support her child, she should actually move out. There is no need to staying there and being domestically abused.
Makes sense. Makes sense. All I was thinking is if the woman has an independent source of income or some other way of supporting herself. Usually in our country, and I have heard my wife say that hey, if my daughter is facing the same situation, I will go and get her out of the husband's house. But I'm thinking more of, okay, I stayed in this house for many years. Why can I not stay and then eventually build up enough financial, I guess, footing to move out? But I'm happy with what you said.
I hope I answered your question.
Yeah, thank you.
Dr. Sabina, I'm just checking whether you yourself do have any kind of comments to the presenter so that they can respond to the questions posed by the discussant, Dr. Rubana, and also if you have some questions, then we can actually have the responses from their side, and then towards the end, we'd expect you to have the closing.
Yeah, I was going to open it up, Dr. Salim, because we have so many participants. We may want panel speakers to ask each other. I've got some overall comments when we wrap up, because I thought Professor Romana covered some key points, but I don't know if there's anyone else in the online audience. যাদের প্রশ্ন থাকতে পারে, you may have questions, or you may want further clarification either from each other or from any of the speakers, because I didn't want to kind of hog the time, because আমার একটা ছোট wrap up আছে where I can cover some of my points. But I thought Professor Romana spoke really well. So is there anyone else who has any questions? I know in the chat box কয়েকটা প্রশ্ন ছিল, beyond mental health, are there any questions around health systems or the vaccination? I mean, I have some questions, but I'd rather wait for the audience, to be fair. I don't know. Arki or Prosh, no one has any questions to the esteemed panel and the speakers? No?
I have a, I'm not sure.
Okay, good. Okay, good. Go for it. Yeah, please.
Into, I think that was on the second presentation, especially when we talked about the third presentation, we talked about the school and also how, especially those modeling, and then how to open up the schools. You know, to what extent, because I can see that some of the very health experts involved in the government committee, they're also there, especially, for example, Dr. Abul Zamil Faisal. So to what extent actually you have been able to engage with the real policy making, you know, because these findings and these surveys are extremely important, as mentioned by Dr. Luana Hogg, generating this kind of information during the COVID time. But how this information actually helping the real policy making, because I can see a real gap there. And probably that's the same question to Shafi and Shimul too, because you know, when we see this kind of initiatives or the steps taken by the government, to what extent those are based on real evidence, you know, or simply just hunches or, you know, just wishful thinking. Yes, that's my question to both of you.
Thank you for the question, a very important question. I will start by first speaking about evidence. So basically, there are 3 or 4 strategies we have to control or contain COVID. One is school opening and the other is mask wearing. If you just compare those 2 strategies, mask wearing has much more evidence internationally that it is definitely much more effective. School closure, in terms of school closure, international evidence, it's mixed. It's very mixed because different countries. So in terms of total evidence base, it's not there. Therefore, keeping school closed, mask wearing is much more effective. So that's what the total evidence is internationally. Now, coming back to policy and implementation. And well, when I talk about policy awareness, right? Because someone was saying that we need to have skilled labor force. Remember, at the start of the pandemic in Bangladesh, the communication budget was set to 0. So, you know, when you have a pandemic that is coming, you don't set your communication budget to 0. That was done. Now, we're also working in a very siloed environment, right? The Ministry of Health does not talk to the Ministry of Education. So I don't know, we have been trying our best to inform as many people as possible to saying that, okay, you really have to consider school opening. But there is a certain reservation. There's a certain reservation because people think the school opening will make it much harder. Our point is it will be harder for the next 2 years. COVID-19 is not going away next month. It's not going away after the Eid. It's not going away by end of Eid. So we'll have to manage this for the next 2 years, like it or not, with or without vaccine, because we are not going to get 100 million people vaccinated in a short period. It'll take us at least a year. So how are we going to manage that? So one of the things is you have to implement mask wearing. But at the same time, as the last Sarah mentioned, we are having devastating effect on our children, on our future, essentially, and that we cannot let, you know, we cannot, you know, basically we have to figure out some way. Shafil Shimul, did you want to add something?
Yeah, thank you very much. So since we both are in the 2 of these studies, so we have some common areas. So thank you, sir, for your question. Actually, we actually did that projection model. We have presented this thing to the government several times. I mean, the DGHS people, including other advisors. So government, in fact, in the last time we did in April, and when the infection was going down, we said that there could be another spike. So the government has, I think, has taken it seriously because we had like 3-4 groups. One group said probably there will be another, no other spike, we are done. But 2 modelers, including ourselves, we said no, there could be another surge, what we are seeing now. So government has taken it seriously. I mean, I'm not sure how much that has changed their policy, but what they kind of said, they took it seriously. But in terms of vaccine, I think we didn't get chance to share with government directly, but it got a good media attention. I hope government has noticed. But initially, you have seen that people are really encouraged to take vaccines, but now that that sort of encouragement has gone down of late. So maybe our third wave can dig out more other issues of what are the consequence of the recent upsurge in April and recently, whether that has anything to do with encouragement to get vaccinated. So yeah, but in terms of policy engagement, I think the vaccine study is not that great, but the other study, I think it was very good. Thank you.
Any other questions from anyone else? If no one has questions, I was going to share some questions, comments. Does anyone else have any questions? Can I come in? So I was just going to say they're all very fascinating. And I was just thinking about the whole vaccine issue, because our research, the school is undertaking lots of surveys, qualitative research, and there's a lot of vaccine hesitancy and a lot of mistrust around the vaccine. And I think this reminds us that if we can't have other kinds of enabling positive reinforcement, either employers, provide a space for vaccines. I mean, now we're in a shortage, but should we get the next supply? How do we address some of the socio-cultural challenges and issues around vaccine use? Because some of the research we're finding amongst women, access and mobility and registration is an issue, but also there's a real fear around vaccines and a general distrust of vaccines and chemicals and where it's coming from and what it's going to do. Because historically in our country, we've never had adults getting inoculated. It's been children, right? And so it's kind of a new way of looking at things. And I think the politics of it is important. I was thinking about the socio-cultural school closure stuff. And I think what's important about the school closure, I really enjoyed that because I think it's so important. We're losing a whole generation through school loss. And I was thinking about urban slums and poverty, Dr. Mufakkar, because here, urban slums, there is no distancing. You've got so much crowding and congestion. Are there spaces where we can think of alternative ways if we're going to reopen schools? So actually, my main point is that when we implement and try and think of implementation, and I love the fact that you talked about community engagement, are there ways we can engage with communities to figure out those sorts of practical solutions? Because in some spaces, even though in many slums, they're not scared of COVID, they used to be scared last year. How do we create those spaces? How do we also provide subsidies for masks? How do we create spaces for uptake of certain kinds of services? And my point to the health systems preparedness, that pandemic in our region, is that we have a human resource shortage in South Asia. And secondly, budget allocation. Beyond a budget allocation, are we looking at alternative models of task shifting? Other players in this system. In Bangladesh, and I can't speak for other places, the private sector in the formal sector plays a huge role. So in some ways, referral, and I agree that you have to improve quality of services, but we also have to take in this complicated space of the private sector, the informal sector, and how do we bring them into the conversation? Because otherwise, it's very difficult. One, there's a human resource shortage. There's the politics of doctors and pharmaceutical industries. And then you have the informal or the private sector playing a much bigger role, and people rely on them much more. And I thought it was very fascinating looking at the differences. My final thing with the mental health was I thought it's really interesting because it brings back the main point that a human being, we have to look at health comprehensively. So the reason why I enjoyed these presentations, it was an honor to chair it, is because we looked at school, we looked at vaccines, we looked at, all kinds of other processes looking at mental health, but really it's talking about the human being holistically. Because if you are mentally and emotionally distressed, be it a lack of jobs, or food consumption's gone down, or your children can't go to school, or you can't afford schooling, then we have a huge domino effect over the next few generations. And I have to agree that if we don't actually start opening schools and taking steps to address this, we are going to have an insurmountable problem. So I just wanted to just share that. And I wanted to say it was a huge pleasure. I learned a lot. I'm a medical anthropologist. And for me, it was just great to hear these diverse perspectives from really, really interesting, solid pieces of evidence and work. So congratulations and thank you. Thank you.
So Dr. Sabina, shall we get some responses from the presenters, especially after their hard,
I'd love to hear back.
Your intervention. So one by one, if we can, starting from Shafin Shimon, please.
Yeah, thank you so much for your nice feedback. It is always a great pleasure to get feedback from Sabina, including, I mean, since 2008. So she has been always phenomenal in terms of giving suggestion. And I mean, I just want to share one thing is that your study on sexuality, I always quote, I think I quoted it in maybe 250 places that how to do research. So to get data when it's very difficult to get data. So I think your feedback is incredibly useful. And also I want to thank you, Romanapa, for her excellent review. And as well, I think she read all these papers very carefully. It's really commendable. And also, I mean, she has been extremely busy these days, but she could manage time. And I think all these points raised by Shibli Bhai and others, all are well taken. And of course, Salim sir is always phenomenal in terms of suggestions and the research ideas. So I am very proud to be in this part of this process. Thank you so much for your suggestions. All are well taken.
Can we move to the next one, please? And
yes. So we want to thank the opportunity given to us by Sanem to present our paper. And we really appreciate the feedback from Dr. Romana regarding how budget allocations should be done more effectively, and from the start to the end, how it has to be more done in a more effective manner. And we're definitely going to incorporate these comments in our paper going forward. And we really appreciate the opportunity and the feedback. And thank you.
Dr. Mofakar, please.
Thank you for your comments, Dr. Rashid. What I would like to emphasize on your point about the task shifting and new and creative ways, we do have to come up with new and creative ways to get children back to school. And private sector can play a significant role, has been and will need to play a significant role. But there are potential ways of getting back, and different countries have tried all kinds of different ways, because it's a long-term involvement, and we need to get students back to school. Thank you.
Thank you. I think before requesting Sarah, there is a question I can see from India, Firdaus Malik. Would you like to raise speak, or I'd like to read out for you, Mr. Firdaus Malik? I think I can read out. I have an observation from rural school in India, especially from the region of Kashmir. Parents are facing the problems of supporting devices like phone and laptop because of having more than one children. Now, question of vaccine, people in rural area are denying because of misconceptions. How can we manage these issues, and how can we represent the demand basis issues faced by students and parents as per online schooling is concerned? So I think there are two sets of questions. One is that vaccination in rural areas, about the conception and whether to take or not to take, and that's what I also would like to hear from Dr. Sabina and others too. What do you feel in Bangladesh, and also probably Chatuni from Sri Lanka can also speak up. What is the kind of from Shafiun's present the survey. Do you think the same kind of things are also happening in Bangladesh, in rural Bangladesh or rural Sri Lanka? that there is a misconception about taking vaccine. And the other question was about this electronic device. So probably about the vaccine, would be happy to get some feedback or response. So you want to start from Sri Lanka or
is
Bangladesh?
it Chatuni to respond? Oh, sorry, I'm confused.
Yes.
Okay.
So in terms of vaccines, I think there's some level of enthusiasm for people to get the vaccine and be vaccinated and for things to go back to normal. And I would actually like to highlight on the point about education and online learning, which has become a bit of an issue in Sri Lanka as well, especially in rural areas, because schools have been closed for a better part of a year, I think, at this point. And we're also currently facing travel restrictions and schools have been closed. And there hasn't been any, implementation of online learning, a proper framework to address these issues that have arisen in rural areas. So there's a lot of complaints from children in rural areas about not having access to internet and not having access to these devices, and this risks them being left behind in terms of schooling and could entrap them in a cycle of poverty, and therefore has long-term implications for Sri Lanka's labor market and also competitiveness. So yeah, that's what I wanted to highlight about that point. Yeah.
Thank you. Shafiun, would you like to add anything from the perspective of Bangladesh? Because they often blame the people that they were not aware, they don't have the demand for vaccine. But as pointed out by Dr. Sabina, I think it's an extremely important point, especially it's the vaccination of adults, not the child. It's a very new phenomenon in Bangladesh.
Exactly. So yeah, I mean, the what we found in our studies also, like, the perception of risk is also relevant to willingness to get vaccinated. So that the reason people don't wear masks is because people just perceive that it's not that risky, that they under-perceive their risk. Now, here comes this cultural effect. You have to develop a communication material that's culturally sensitive. I mean, that has to be done. And unfortunately, all the drive we have seen since COVID is most of administrative, instead of looking at what we can do to aware people. Instead of awareing people, we're just blaming them. I think we have to work back and then see what we can do so that we can increase awareness, just not for COVID management, but also the vaccine effort to be successful. So yeah, that is what I want to share.
I just want to raise, because I don't want to lose the opportunity of asking Dr. Sabina, because I want to pose the question to Sabina also, and also all the honorable participants. Here in Bangladesh, what we have seen, and also like to hear from Sri Lanka, that the registration for the vaccine and the age bar is 40 or above. But there was, I remember that, from the very beginning, probably many of us actually are saying that let's get all people registered, irrespective of their age. And then probably, we can actually keep those age bar to give the priority, to the people who get vaccinated. But now, you see that a large chunk of people, they are not actually even registered. So how do you really then, get this registration process and the whole vaccination process ongoing? And then keep aside that whole issue of the availability of vaccine. So that's another big issue. So what is your take, Dr. Sabina, actually, about the registration process?
I think there's two things. I think, what happened when last year when the COVID shutdown happened, we had a lot of enforcement of surveillance by army and police with lockdown. That is not the way to get communities and populations engaged. I do think we need to rethink our messaging around vaccine, but also then create a space where employers, restaurants, schools, jobs, it's set up that people have to be vaccinated. So it's a kind of a subtle pressure with the messaging that creates that enabling space where they're told it's needed. Because some of our research is finding that those who are living in informal settlements are saying, oh, my garment worker employer will not let me join if I don't get vaccinated. Then we create the spaces in the garment sector when we get vaccines, because now it's hypothetical, we're in a shortage, to create that space for them to get vaccinated, because registration is an issue, access is an issue. But I think it's a bit of both. We have to give messaging. We're not robots, we're human beings. There's a lot of vaccine hesitancy amongst middle class, well off. So we're far more strategic, and we know we'll get access much easier. The poor are saying we're not dying, the rich are dying. Why are you trying to enforce vaccines on us? So I think it needs to be a multi-pronged approach. Schools, garment factories, other factories, working spaces need to create that space where if you work with us, if you're a security guard in this company, you need vaccines, we'll ensure you get vaccines. So we don't exclude people who are not vaccinated, but create a space so they can get vaccinated. But then it's sort of this multi-pronged approach of messaging, communication, and creating that environment where they're actually pressured to get the vaccines. I think it needs to be a bit of both. That would be my suggestion. I'm not a implementer, but I work with communities and people. As an anthropologist, I think you need both. You can't tell people what to do, but if people recognize this will affect them economically or socially, everyone in their neighborhood, in a slum settlement or a village is vaccinated. If we have community local ambassadors, people they trust, the local pharmacist, the local imam, people will get vaccinated. It's a very, very step-by-step process. We have a history in Bangladesh of doing this with ORS, with TB, with family planning. It's just that we jumped into it and we're trying to do a rollout. But in the past, the successes of our programs have been based on community engagement at every level, having dialogues, having discussions, and putting pressure in a very social kind of pressure. And that sort of subtle pressure is very helpful. And then providing the means to get that good, be it family planning, and in this case, vaccines. That would be my feedback. Thank you.
Fantastic, Dr. Sabin. Actually, that's what I was really hoping to listen from you. I think that should have been the kind of strategy. I can't remember that I have seen any kind of program even in public media like TVs or other TVs about creating the kind of awareness for the vaccination. Also, I just want to share one piece of information, which SANEM is actually conducting a survey, weekly survey of garments workers with MFO for the last more than a year now. And the very recent survey shows that only 2% of the garments workers, they got the vaccine. But the more probably encouraging fact is that 65% of the sample in the survey, actually, they showed their preference to get vaccinated. So I think this kind of encouraging, probably garments, ready-made garments is a kind of separate enclave because they engage more garments associations, and there is a process of creating awareness. But I'm quite sure that it's not the story for the rest of the country or the rest of the workforce. Yes,
can
please.
I make a point? I obviously don't live in Dhaka, and my sample might be biased, but I sample the people I talk with every day about why isn't everybody vaccinated? And the point you raise, which is, how do you register someone who doesn't have an iPhone or doesn't have the NPI card or is not privileged to go to a vaccine center? So that's one of the things I keep on harping on in my work on Bangladesh. Please make vaccines available to everybody, and that's not just nominally, but make it accessible. So if there are roadblocks, the NPI card, I don't know what percentage of the people who work in the rural areas, in the SMSE, small and marginal enterprises, they have that facility. You guys can answer that. Thank you.
Thank you, Shili Bhai. Thank you. I think I have seen a hand raised by Jahidul Qayyum, and we should let him speak. But before that, just checking with Chatuni from Sri Lanka about the registration process of the vaccine. Do you have any age bar, or everyone can get registered in Sri Lanka?
So only those above the age of 30 can get registered. So that is the process for now, given the limited number of doses. So so here in Sri Lanka, we've actually seen people, queuing up. There are long queues at vaccination centers and people complaining that they weren't able to get vaccinated. So I would say that there is a certain level of, enthusiasm in people to get vaccinated. So the issue here has been that it's the limited number of doses, so which is kind of encouraging in one way. So yeah, that's the situation in Sri Lanka at the moment.
Thank you. Mr. Jahidul Qayyum, you raised hand. Could you please briefly introduce yourself and
okay. Right. I'm Zahidul Qayyum. I'm a professor at the James P. Grant School of Public Health, working at the Center of Excellence for Health, Urban Health and Equity. Just a couple of things, and of course, just a question when you raised and wanted to hear, and I think it was just, and Professor Sabina has really given a good example with Bangladesh context, particularly with the reference to different family planning and others. So I just would like to add, I think she has covered most important things that you have mentioned. Just would like to add that in context, and say for assuming that we have the supply available, is the issue of we want to create the demand or the kind of motivate people that they take up vaccine. A couple of issues here. One thing is like, and also like some of the issues like Professor Sabina mentioned, that there are other cultural, and also Safiyun has also mentioned. What I would like to mention here, the importance of people understanding the value that, or how important it is to take the vaccine. Now, we don't have sufficient data or the knowledge or information available who are the most risk group. We know it very well, and from evidence from all other countries that particular morbidity condition are people are prone to that, the negative effect or the kind of a danger or the problem with COVID. So say we can say that, well, these are the group, and also like some of the thing we have to do in the kind of a motivating people that how important it is. Like, child immunization, this is important that everybody can understand the value of the life, because child is more important than future. And the other things is like, that we would have the risk group of the population is an important, and also identify. And now the issue that comes up, okay, how do you do it? And given what we have, the infrastructure, we didn't have a long time ago, no ID system. There are so many other things, so other infrastructure or institution we can have. Of course, we know that there are so many other institutions. So my point is to motivate people through whatever institution, either at the community or at the formal sector, or even in the rural community sector, and kind of design our motivating people, communication language, whatever you say that. But the thing is, the value of having a vaccine, and there is no other alternative, and I'm convincing people that we have to take it. There is no other alternative. So that's the kind of a thing issues that, and then another thing as an economist, what we believe, the positive externalities, that's the kind of a thing we want to really motivate people, that the external benefits, you having the vaccine and you helping the others, other helping you. So that are the things, those are the things important to kind of say in that story. Thank you. That was my kind of a main proposition there. Thank you.
Thank you, Dr. Jahidul Qayyum. I think it was a fantastic session. I would say that I learned quite a lot. But I request Dr. Rubana Haq to say any final words, and of course, the closing remarks will be given by our chair, Honorable Chair, Dr. Sabina.
Shall I?
Yes, Rubana, we can hear you.
Thank you. Again, excellent session. And I think in the presentation of Dr. Shafiyun, they identified the demand side issues, but equally very important is the supply side factors that I mentioned during my discussion. And I think the entire vaccine management, Dr. Sabina Appa rightly mentioned that we are not used to, the adult vaccination. Another thing is that during this COVID period, it's my perception that the population dynamic really helped us. After 10 years, when the majority of the population will be old, and now the population dynamics that is favoring us, it will be the other way around. So then these vaccination, all these will be really important. So maybe at this time we could survive, or economy could even turn around despite this pandemic, just because of large number of young population in the country. But for these lessons, I think we have to plan very carefully and create the roadmap that how we can take these lessons forward for any type of pandemic management, and considering the different population dynamic which is going to be in next 10 years with more older population. So thank you again for inviting me. Just as got the microphone, the last point, the mental health and multimorbidity. I think this is really important, and we really have to make sure that we consider mental health in the agenda, and the antimicrobial resistance. Another issue I've started raising my voice, that during the pandemic, the way we used the antibiotics, so any modeling or somehow this needs to come up, that how we are getting resistance, and this will increase our healthcare expenditure manyfold in the upcoming days. So this type of platform really gives us the opportunity to raise these issues. So I hope Sanem will continue engaging on health sector issues also. And again, thanking everyone for giving me the opportunity to say a few words again.
Thank you, Dr. Rumana. So Dr. Sabina, over to you for your final words this year.
Yeah, I'm not going to keep everyone too long. It's been a fabulous session. I learned a lot. Just a couple of key things, going back to the theme of the conference, context matter. Community engagement is key, whether we're talking to young people, whether we're talking to diverse heterogeneous communities, whether we're talking to health providers, whether we're talking to doctors, whether we're talking about quality, supply, demand. I think what I've often seen is that if you look at South Asia, we also have many homegrown localized solutions because our contexts vary, the language barriers, the social barriers, the cultural, religious. I think sometimes we need to go back to the table and see what worked in the past and what we can learn from during this pandemic. I thought the presenters had excellent suggestions and recommendations, and sometimes there are simple solutions to address many of these, and sometimes we need bigger sort of multi-sectoral approaches and investments to address some of the more complex issues around health systems, service delivery, but even issues around poverty in schools. So context matter, and I think we heard diverse range of speakers. I wanted to say thank you again to Dr. Salim Ryan for inviting me and for moderating. And I want to also thank each of the speakers and each of the institutes. Really, really enjoyable. And I wish you all the best on your papers, but I hope you can actually present this, publish this, and share this in different forums, because often it just stays in a conference. And these sorts of findings are really important to get out there, whether it's in the newspapers or policy briefs, but can you please just get it out there? Because I think it's very important for us to learn from each other. Thank you very much and have a good evening, wherever you're at. Thank you. And thank you, Rumana Haq, Professor Rumana, for making my life much easier. She had to do the hard work of actually critical reading. So thank you for that, Professor Rumana.
Thank you. Thank you, Savinappa. Good to be in touch.
Thank you all for being with us on this third session on COVID-19 and public health. Our heartfelt thanks to the chair of the session, Dr. Savita Faiz-Rashid, and also to the discussion of our session, Dr. Rumana Haq, for their time and excellent observation and remarks. We also thank all the presenters and participants for joining us today. We hope to see you again tomorrow. We have 4 exciting sessions tomorrow. The first session will be at 10 a.m. The session we'll have papers from the South Asian economic students on a variety of issues on this region linked to COVID-19. Special guest of the session will be Professor Wahiduddin Mahmood. At 3 p.m., we'll have a panel discussion on COVID-19 context and priorities, gender perspective, where we'll have leading gender economists and experts from South Asia speaking on the issue. At 5 p.m., we'll have trade and macroeconomics session 2. And lastly, at 7:30 p.m., we'll have a panel discussion on COVID-19 context and recovery South Asian perspective. Session will have eminent panelists like Professor Rehman Saban from Bangladesh and Professor Deepak Nair from India. With this note, we would like to close our today's session, and we look forward to see you tomorrow. Thank you.
Thank you, everyone. Thank you. Thank you so much.
Thank you.
Okay.
Bye-bye.
Good night.
Bye.